So I wish I had listened to this talk a few years ago. It would have saved me a lot of trouble. Take it seriously. My name is Panos Vostanis. I'm a professor of child psychiatry in England, the University of Leicester, and also I work clinically with the group of children I will refer to as vulnerable who experience trauma, particularly those with sort of more extreme forms of social exclusion. I was not certain either of the time, so I may need to focus on intervention, some key aspects, and then go through some of the practical aspects later in the workshop for those who wish to join. And also, I wasn't sure. Obviously, there's a mix of us, a mixture of colleagues working with young people and others with adults, just to get a feel how many of you are working with children or adolescents. Okay, more than I thought. And the others working with adults, working with parents, young adults. Okay, so it will be relevant to everybody because the two are so connected. Any of you working in particular or as well as with any of these groups, with homeless or those who take drugs? Or I'm talking specifically about services. No? Okay, so some of you who work particularly in this field. Because many children will have experienced these traumas, but we're talking more about those with complex or chronic traumas, are different terms used in the literature. And I was planning just to give an overview of the status, what we know, just pull it together, what is different from the rest of the field, and then focus on maybe some key messages about interventions, but also about services. And then we can go through in more detail later on for those who wish to. So the difference is that you know these children move around. Their needs are not, by meaning complex, they're very strongly related to social care needs, to the behind at school, developmental delays. So very difficult to separate, but also what I call here secondary effects. That is the effects of being in care. In some countries you have orphanages, in other countries you have foster families. Therefore they come in contact with many services but at different times. And the paradox is, which struck me when I started, actually the more problems they have, the less they access services, which doesn't make sense. And the understanding behind it is that because they move around and they do not have stability or one carer to advocate for them, they miss out, and certainly mainstream services are not geared towards them. So talking about problems, I mean, it's easy to forget the protective factors. For those who work with children, a lot of the time psychological interventions, it's not that they're not appropriate, may not be possible for that group or at all times. And even if they do, you have to work at different levels. So it's important to remember what is obvious, what with good research background, that now it's particularly the attachment theory has influenced our field. And the good message is that it's not just one carer now, that these children can form attachments with multiple carers, important for teachers, mentors, not just family or extended relatives. And the rest is more about forming relationships. It's not just being at school and performing well, getting good grades. It's more about being equipped to develop coping strategies for later life. So if you reverse that about the risk factors, and again, we're not talking about one here, we're talking about multiple and a chain of effects. The main two, violence and abuse. The acute life events, if anything, have relatively better prognosis, much easier to deal with in the absence of anything else. The problem is these come with chronic adversities, where the family conflicts, I'll show a graph in a minute, which are much more difficult to break. So that's why I ask those who work with adults probably have a much better chance of influencing changes than those who only work with children, because parents and the main carers are crucial. So when we talk about traumatic experience, again, being in Greece, it's a Greek word, trauma, physical one, but the parallel is striking, and the majority of children with the parallel I would use is that they will have scars, or that trauma will close, but some of them will remain open, and that's the group we're talking about. So if we start from the bottom, from the more specific accidents, again, they may have better prognosis, as I said, in the absence of anything else. When communities are affected, we've seen the situation in Nepal. It's, that can go on for months and years to rebuild, and it's the indirect effects are much more difficult than the direct exposure to trauma. But the majority now we're talking about that you are in contact with are those with domestic violence, abuse of different kinds, and we tend to see the world is much more mobile than it used to be. We see refugees and people who experience traumas all over the world. So the impact, as I said, it's acute and chronic. It's the direct impact, how children experience violence because they're affected, they're frightened, or in whichever other way at home or in the community, but also the indirect impact through adults. So a key mechanism usually through mothers, if the mother is weakened or frightened, and that affects her parenting. I'll show a graph in a second. And that can be a much more powerful mechanism and more difficult to break. And then you have the secondary impairments because they are in care, they're more exposed to exploitation, to trafficking, to being out of school, missing out on friends, and so on. So that's the difference of working with a specific type of trauma. So just to show it sort of visually, so you can have, as I said, the direct one, which is not, nothing is easy, but it's probably the less difficult to break. But you can see the other mechanisms here is how it affects parenting, parental mental health. And the reason these arrows are in yellow is because that's the most powerful mechanism here, is how the parents or single parents or whoever is the main carer is affected, and that can make things worse. And then social adversities on their own don't cause problems as such, but they are connected, they are associated with all these factors as well. Again, also an epidemiological sort of study. And for those who work with, particularly with children, you may use different words in the adult field, but the reason that the attachment theory has really influenced our thinking is because we interpret behaviors very differently. You can have social learning behaviors, because of interactions and lack of boundaries and so on, but a lot of the aggression we see, children who are in care, who have been victimized, have suffered trauma, is because they cannot regulate their emotions. So it is because of disrupted attachment. So the meaning of these behaviors and aggression is completely different. Therefore, the interventions are different, at least some of them. I'll skip a couple of those. Just to show, again, what you would expect from epidemiological studies. There have been several, 3 national surveys in the UK in the last 10 years, 2 in the general population and 1 specifically for children care. They're called Looked After Children. And I think it's the middle group that's quite interesting. If you look, the gray bars, they show the prevalence, the rates of disorders, problems, whatever words one wants to use, which are fairly consistent across the world, about 10 up to 15%. So roughly 10% there. In the general population, if we move into deprived areas, that is in poverty, but with relative stability, it goes up to 15, sometimes goes up to 20%. So if you see children in care, living without parents in residential homes or with foster carers, it goes up to almost 50%. The numbers don't matter so much, it's the pattern really. You can see how accumulation or risk factors affects them. And it was the same if you look at specific groups, behavioral problems and so on. I'm sorry, I'll speak those. I wasn't certain of the time, but I'll skip those for the workshop. Just to give a couple then of examples of some studies we've done over the years, just to demonstrate this pattern. No need to read all the details. I'll highlight a couple of points here. These are families who call homeless families, they're called in the UK, but effectively the majority are victims of domestic violence and they live in shelters. So they may not live on the streets, but essentially they flee violence. And the key patterns here is that the mothers had their own histories of sexual abuse, almost 1 in 2 there, either as children or as young adults. And that was the strongest predictor of the mental health problems at the time. It was mainly depression, severe anxiety, or PTSD. And that was the strongest predictor of problems in children. Again, the numbers don't matter. They're high, but it's textbook stuff, that mechanisms, how trauma affects adult and child, and the adult affects the child even more. And that combination is the key to break. And that's a narrative from a qualitative study with these families. The numbers are powerful, the narratives are even more powerful, what the children remember. And young children had very, very vivid recollections of what they had witnessed. In a number of studies, as I said, I'll just use two selectively. We've been working with colleagues in Gaza and the Palestinian territories, which where the situation is extremely hard there for many years. And I mean, in recent years, there have been a number of studies in similar situations, very straightforward association between exposure to trauma and PTSD in children and adults. But when we started back then, it was, there were not many, particularly with children reporting trauma. So you have what you expect, high rates of PTSD, emotional disorders. What's interesting is the different pathways, and it's been shown in other studies, particularly in the US with war veterans or refugees, that trauma is directly associated with post-traumatic stress. We can debate whether it should be a disorder or a label when we have time. But depression and anxiety are mediated by current adversities, by poverty and living in overcrowded areas. So you have both direct and indirect impact. I'll skip those for the workshop. That may be interesting about the discussion overall about this conference and any conference on the status of therapies and interventions in how they're applied these days. And I'm personally very envious of those of you starting now or in training or relatively young in services and in practice, because you have a much wider, broad choice of interventions. And the evidence is it's not huge, it's not great, but it's getting better. And the question is how one applies them. So that's what we're used to. I suspect the vast majority of you come from this field, working in specialist, relatively specialist roles. These are the big schools, but all the big schools have evolved, have broken down, the psychoanalytic, psychodynamic, then we have the behavioral, cognitive, and family systemic or sub-schools. But we also have applications that are used more and more, but they're also not sort of as defined. I'd be interested if we have time to hear your views, how you apply them best. About teachers, I just had messages about specialist teachers the children I work with who are adopted or who have attachment difficulties. They all apply these sort of universal sort of forms of interventions, all apply behavioral strategies, supportive listening or talking, counseling. They're used so intermittently these days, which is great, but it can be quite confusing as well or not very clear, or family work. So exploiting, maximizing the breadth of these interventions and people around, particularly in countries without specialist resources, the slide I will finish with, is hugely important. I think the questions more are about who does what and why. So eclectic doesn't mean we do things by default. It's more about choosing what is more likely to work. And this is the range of interventions. Again, be interested to hear your views about your experience or about relevant interventions with adults who suffer trauma. These are not mutually exclusive. I think it's more about deciding when it is appropriate or it's possible to use any of them. Because otherwise, as I said, there is confusion. People can use them because nothing worked and keep using something else, and it doesn't work either. So again, the older ones like social learning-based theories, everybody uses them. They're not specifically to treat trauma, but they're very powerful in containing symptoms, in containing problems, and allowing other things to work. Again, they can be misunderstood or misinterpreted. There is evidence with adolescents, even with very difficult groups, refugees or who've been exposed to war trauma, of cognitive based interventions. Some adolescents prefer them, particularly boys, not necessarily, I wouldn't generalize, but sometimes they find it easier than the more free sort of associations of narrative exposure therapies and so on. So it is a good tool if it's available. And there are some, I won't go into sort of details like EMDR, which have some cognitive elements as well. then we have the majority of what probably the majority of us sort of started with, and here colleagues work very much in the psychodynamic field. Again, these have evolved to become more specific about trauma. I mentioned the word narrative exposure therapy. These have evolved from 10 years ago, where the more guided type of interventions, I think, have been abandoned, giving people more choice. Some are ready and some are not, and the same applies to children. And I would say this is not necessarily new. Attachment theory is not new, but attachment-based therapies are relatively new, and they're evolving as we speak, and their evidence base is building up. And the difference here is recognizing that unless you work with a carer on the relationship of the experience of trauma, because these children have not had that experience, working only individually either will not be enough, or the problems will recur, or the adult will inadvertently reinforce them by just dealing with the behaviors. So there are a number of, there are variations of attachment-based therapies. There is the bit earlier one of parent-child psychotherapy, where the parent is involved or the carer intermittently, either in parallel or at different intervals. Theraplay is a hugely expanding one in many countries, predominantly from the Theraplay Institute in Chicago, but many countries we use it an awful lot with groups, where again the carer is involved in, you may do emotion regulation work or therapy with a child, and you bring the carer in at different levels depending on their reflective capacity to help them nurture the child. And then you have the more difficult ones with mixed findings for adolescents who, with recurrent self-harm, find more difficult to reflect. I don't want to use controversial terms like personality disorders, but that's sort of the group we're talking about. But there is some promising evidence about dialectical behavioral therapy, where again the focus there is slightly different. It's not necessarily about insight, it's more about coping with risk and distress. Medication is not the first line of treatment, and it's not for trauma. Sometimes, I say with caution, because in places it can be used too generously. It's only to deal with symptoms and to free others at the acute stage. And there are a number of interventions, multimodal interventions, as I would call them, particularly coming from research centers in the US, which are not cheap and are not easy, like multisystemic therapy. Got a good evidence base. I think the problem is rolling them out, but the principles are very useful, and the principles go back to the beginning, what I said, that you have to work at different levels, work with the child, the family unit, but also with school and community, and that's the ideal model, whatever the level of need is. And that's a group, this is a group was, I would call it a CBT group, but it was, but the boundaries are not very clear. It's one interesting intervention from the World Trauma Foundation in Norway called Writing for Recovery, although the word writing is loose, really, don't necessarily need to, it can be narrative as well. And we use it with refugee children in local schools, and I had my doubts whether it would be effective because of their age and all sorts of difficulties in whether socio-cultural language difficulties, but actually the children were using particular techniques adapted to the developmental level. That's very important to remember. So for example, this child was walking into shops whenever there was a sort of noise, was sort of startled, and he was beginning to use techniques to self-regulate his fear. I think we're finishing in a few minutes. Nobody's coming. 2 minutes, good. And another important point about interventions, working with carers, that's the difference working with the majority of children. In the majority of children who have behavioral problems, they tend to be related to discipline, to boundaries, either giving in or spoiling them a bit, or being overprotective, or parents being anxious. Here the behavior, as I said, have a completely different meaning. The behavior comes from trauma, from horrible violence, from years of neglect. So and they have not had the behavior of the parenting either. So the problem that carers have, like foster carers that we work with, or carers in whatever institutions you have in your countries, is that they have to instill some behavior strategies, but the child will interpret them differently. So that message, which sounds obvious, is not obvious to them at all. So any attempt to discipline will be experienced as rejection because they've been kicked out before and so on. So one has to work at both an emotional and behavioral level at the same time, which is not easy. I think I'll finish with just one point about sort of service principles. When I said at the beginning they do not have much access, if you look at let's say at a relatively stable family, at a child where presents with emotional or behavior problems, but you have the family in the middle, you can see the lines are pretty thick and solid. And then you have the community around them, particularly school, and then they have services. So they're fairly sort of strong layers to access help because they have anxiety or fears or nightmares or whatever, or behavior problems. But if you move to the next level, a child who is homeless, refugee, or from the groups I talked about, this one is the family unit is either non-existent or weakened, and then the same applies to the community, no networks, extended relatives, or they may be out of school because of all these reasons. Sometimes they flee violence, they lose their school and friends, therefore they cannot access services, and that explains that paradox, which maybe we will have the opportunity to untangle a bit later. This is how we have tried to deal with it where I work, and I mean, ironically, as you speak, with the economic climate, we're under the first time in 10 years, we're under enormous pressure to lose our staff there, or some of our staff. So the reason we work directly with these groups is for those who are in public care, in foster care, residential, refugees without parents, adoption, those who are homeless, and those in contact with the courts. But these are not good days, I think, in the UK for the public sector, despite what you hear in the media. So we'll see how we survive in the next year. I hope it wasn't too rushed. I tried to give some basic principles, what is different from working with other children or other young people. And hopefully, if you wish to go through more the practical aspects, we'll have time in about half an hour. So thank you. And there is I think there is a change in the next speaker. The next speaker, I don't know who the next speaker would be, I have the name, could not make it, but you were due to speak yesterday, so you're coming, you're speaking now. Yes, okay.